Hello everyone, I'm Ron Rolfing and I'm the Preferred Vendor Coordinator here at ACAP, and I'd like to welcome you to our latest education series webinar presented by Z Omega. Our presenters today are Tricia Swift, Vice President of Innovation and Transformation, Rahul Singhal, Chief Medical Officer, and Praven Pant, Senior Director, Data Analytics and Artificial Intelligence, all with Z Omega. And they will be presenting the webinar, The Value of Leveraging Social Determinants of Health for Medicaid Health Plans. And as you can see on the screen the brief bios for all our presenters today. But before I turn it over to them, I have a few housekeeping items. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines, and these guidelines can be viewed on our website. We will be recording today's call, and we will post a slide deck and recording on our website by tomorrow morning. And the link to these items can be found in the invitation for this webinar that was sent to you earlier. If your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of the page, top of the home page that is, and click on the preferred vendors link. And of course, you can ask a question at any time. You do this by typing in your question in the questions box in the control panel and hit send. And all questions will be answered at the end of the call. I'd like to turn it over to Tricia, Rahul, and Praven.
Great, thank you. I'm going to review, this is Tricia Swift from Z Omega. I'm going to review our agenda for today. So we're going to start off a little bit going with an SDOH overview, just a little bit of the history, definition, and why it's important. Then we'll transition into focusing on clinical outcomes and morbidity mortality as it relates to the impact of social determinants of health. And then we'll end on a discussion regarding the integration of social determinants with the population health management program. And finally, we'll close with some analytics of what this looks like translated into operations. So our next slide, I'll review here the factors for vulnerable populations. So this is a graphic that we use here at Z Omega to describe what social determinants looks like when it's applied to the whole person. So there's a lot of definitions around social determinants. You know, what is it? What things does it include? And there's no one definition that the industry is using. So we do have the World Health Organization that describes social determinants as the conditions in which people are born, grow, live, work, and their age. So at Z Omega, we like to look at social determinants as where health begins, and health starts at the home, with our community, with our workplace, with our schools, and with our neighborhood. If we look at the quality of life in terms of its relation to health, we feel that it's a lot more contingent on things like social and economic opportunities, different resources and support that's available to an individual, the cleanliness and availability of food, water, and air, and the nature of social interactions. So if you kind of look at our graphic here, it's amazing to look at how many determinants are actually linked to your zip code. So socioeconomic factors and physical environment are accounting for 50% of the makeup of things that influence an individual's health. That's half of the things that influence someone's health. If we look at the way we approach health and health promotion, we're not always focused on those things. We oftentimes tend to focus on healthcare quality and access, or even individual behaviors. And while those things are important, the majority of impact is related to SDOH, as we see in many cited studies. So while healthcare quality and safety remains a focus and a priority, we're really accepting now that the definition of healthcare quality is expanding to include other factors such as social determinants and healthy behaviors. And all this is doing is allowing the perspectives to shift to a more holistic and whole person point of view. So our next slide here is reviewing a table for why are social determinants important for Medicaid, and what are the impact of social determinants on Medicaid populations? So we've taken the 6 most prominent social determinant categories here. There could be more depending on your source, but these are the 6 that most people tend to focus on. We'll start with education. Education and low education levels in particular are associated in the literature with an increased risk of major disease, disability, and mortality. These things are due to poor health literacy and unhealthy behaviors that are secondary to just having general education and knowledge of knowing what to do. So when you look at Medicaid populations specifically, around 36% of individuals covered by Medicaid have less than a high school education. So this tells us that education is a very predominant determinant for this population. If we look at transportation, Medicaid enrollees may also have a more difficult time accessing non-emergency transportation. This is also secondary to poverty and income levels. And transportation is definitely linked to one's ability to access healthcare services. So recently, there was an article or an announcement put out by Lyft. They're partnering with LeBron James actually for a bike sharing program. And this is just one example of a transportation program outside of automobiles and ride sharing that actually help underserved communities get access to groceries or even make their way into a job interview. If we look at other things that are influenced by education, which leads to higher income earning potential, we have housing and food security. Approximately 7% of homeless individuals live in rural areas. So if we look at what that looks like and reaching those individuals, they're going to be much harder to make an impact with when we're looking at urban-based resources. Food insecurity, as the U.S. Department of Agriculture defines it, is a reduction in the availability of high-quality food and the variety of food. So it's not necessarily that food isn't available, but it also looks at the quality of nutrition and the variety of nutrition available. And finally, we have social context. So low income is often associated with high-stress environments and high-stress social interactions. So if we look at behaviors that are evolving around social context, such as smoking, alcohol, and substance abuse, many of those are linked to chronic diseases and are commonly seen in the Medicaid population. So what are Medicaid health plans doing about the social determinant opportunity within their population? This is a graph that actually shows many of the common things that Medicaid plans are doing. I think the takeaway from this is that across the board, health plans are doing a lot to address social determinants of health. And there's obviously a lot more flexibility at the state, local levels for how funds are allocated. But even from a federal level, we're seeing integration of coverage for social determinants of health in legislation. We have programs like DSRIP, alternative payments, managed care regulations, and even NCQA standards that all have elements related to social determinants of care coverage and care, which is demonstrating it to be a priority and a worthwhile investment. What I want to point out about this slide is you can see that the most common thing to do for Medicaid health plans is to link members to social services and to do assessments of social needs. This is common, most likely because it's easy to do, but in reality, it can be very transactional in nature and hard to truly make an impact on the population. If you go to the right side of the graph, you see some things that are less common, but could be definitely more impactful. So if you look at offering application assistance for mental health counseling, or even assisting the member to have more community involvement and community integration, these are a little more less common than some of the more straightforward and easier interventions. But if we look at the impactability, and we'll review that later in this presentation, these are the things that have the most impactability. So you have the traditional Pareto principle at play, where 20% of the interventions actually have 80% of the impact. So moving forward, just a little bit of a shift in subject matter here. We have the history of social determinants. This is by no means a complete history. This is a super high-level timeline for social determinants within the history of healthcare discussion and legislation. And we pull this out just to show and demonstrate that we've really come a long way since the 1950s, where in the beginning, we were just simply acknowledging that social determinants existed. It was just included as a statement in various documents and conversations. But in recent years, where funding and accreditation guidelines have adopted social determinants as something important, they're now starting to include social determinants in their guidelines and their funding. However, still to this day, we do not have formal guidelines for what determinants are to be included in the national definition of social determinants of health, nor do we have consensus guidelines on how to measure the impact of intervention. So there's still some work to be done. Social determinants are actually in the current news. So just a couple headlines here in the next slide are very recent advertisements of what's being done at local levels, particularly in North Carolina and Washington, D.C. We're seeing many states and local government officials taking matters into their own hands. This is an example of innovation outside of the federal orbit for how to use dollars and funds to address the social determinant opportunities in their area. But what is clear is that addressing social determinants through things like advanced case management and coordination in the field, healthcare and service delivery, social services and community integration, and deep data analytics that include machine learning and artificial intelligence are all new and different ways of thinking. And that's the type of headlines that we expect to see going forward and reflecting the advancement and progression for social determinants. So at this time, I'll turn it over to Dr. Singhal, who will review the clinical impacts of social determinants and go over some evidence-based statistics.
Thank you, Tricia, for the SDOH overview. I'm going to start by reviewing a few slides from the Centers of Disease Control Summary Trends Report, which they update every 4 years. This is from the 2016 report, so that means in a few months, the 2020 edition will be coming out. This first slide shows the 40-year trend of leading causes of death in the United States. On the y-axis is a logarithmic scale of deaths per 100,000 people. So although heart disease looks like it's a gradual decrease, it's actually a 70% decrease in death rate over the past 40 years. That is absolutely astounding. I lived through some of this as I started medical school in the late 80s and completed residency and practice as an internist for a few years in the 90s and early 2000s. From my brief career, I was able to witness the public health emphasis on smoking cessation, lowering cholesterol, controlling blood pressure, and eating a healthier diet. There was also an incredible explosion of new pharmaceuticals with multiple new medications, including ACE inhibitors and calcium channel blockers for high blood pressure, and statins for high cholesterol. Today, we take this pharma innovation for granted, as these medications are now all generic and cost less than $10 per month. Cancer is, been pretty stable and may soon pass heart disease as the #1 cause of death. Hopefully, over future generations, we can decrease cancer rates similar to what we have done in heart disease. The next slide shows diabetes prevalence by income level. When I first reviewed the raw data from the CDC report, I was shocked. 90% of people that have diabetes have type 2 diabetes, which is characterized by an imbalance in blood sugar and insulin utilization, often with some insulin resistance. Diet and exercise are the mainstays of preventing diabetes type 2 and also managing it. Let me repeat that for emphasis. Diabetes is preventable with diet and exercise. Diabetes is clearly a chronic condition that's more epidemic in lower income areas. You can see a greater than 2x relative risk difference between the lowest and highest income categories. This particular graph is for all adults over the age of 18 who live at these income levels. The results are even much more divergent when profiling people older than the age of 50 in these income levels, with almost a 3x difference between the highest and lowest income areas. Truly an epidemic. This next slide talks about obesity and shows the prevalence across income areas. People have blamed obesity for many conditions, including obviously diabetes, but quite a few other health conditions as well. It certainly is a factor. However, when you look across all the income levels, obesity is everywhere and continues to grow decade over decade. The highest income areas do have a slightly lower prevalence, but it's really not that statistically significant. The next slide focuses on the health habits of smoking and exercise. Smoking, as you can see, although it's decreased dramatically over these past 40 years, there still is a large variance between education levels and smoking rates. I think a lot of the decrease in heart disease mortality has occurred and follows a similar trend line with greater than a 50% decrease in overall smoking. It'll be interesting to see what comes out in the 2020 report with the recent vaping epidemic that I think is crossing all socioeconomic lines and how that may be shifting. As you can see in exercise, also some good news. It has increased over these past 20 years in all the income categories. The upper right has aerobic exercise, and the lower right has muscle strengthening exercise. It does correlate with income levels, as exercise is often more of a leisure activity. When I used to see patients both in urban settings and in suburbs and in suburban, for those people that didn't incorporate exercise into their lifestyle, and for those people that could, exercise and walk, I would really focus on walking. Obviously, some older Americans have arthritis and could not participate in walking as exercise. And just getting people to walk 20 minutes a day, preferably every day, but certainly 4 times a week, makes a big impact on their overall outcomes. Lastly, I wanted to talk a little bit about asthma, as it's quite prevalent and it's often diagnosed during childhood. Asthma prevalence and severity correlates with income levels as well. It has been studied extensively with differences in city populations versus suburbs, and there's a fair amount of research that suggests various toxins in cities as somewhat causative. It's also striking that African Americans have a 2x higher prevalence than white or Asian Americans. Switching gears a little bit from the CDC data, this is a graph from the Journal of the American Medical Association from 2019. It surveyed physician offices and hospitals and asked the question, what percentage of you asked patients about SDOH issues during the point of care. As you can see, SDOH factors at physician offices are asked about 50% of the time, with food insecurity and housing instability at less than a third. Hospitals do a better job of addressing SDOH issues, as they often have to manage disposition during discharge planning, and hence would have to ask questions such as, do you have a safe place to go home? Do you have transportation? What is your housing situation? Interestingly, food insecurity is still on the lower end of that spectrum. Future models are obviously, being explored, and I think the ability to potentially integrate SDOH risk assessments prior to seeing a doctor, prior to hospitalizations, and sharing this data with providers at the point of care, hopefully will be an emerging trend. So I'll be kicking off this last section, and then we'll turn it over to Praveen for the integrated solutions. I'd like to first start off with a case study of 2 work friends who work side by side at the same company, essentially doing the same job. Their profiles are very similar. They're both high school graduates with some college. They have 2 kids, and they actually share a similar health profile. The only real difference is that they live 5 miles apart, with Mary living in a moderately median income area, whereas Nora lives in a slightly lower median income area. So if we were to, fast forward 10 years and project what might happen to Mary and Nora, their health outcomes, if they continued living in their prospective communities, as you can see in this, projection, Mary's health trends continue to be stable. She may have some hypertension over these, next 10 years, but is adherent to her meds and is able to maintain her activity. Nora has put on a little bit more weight and now has a body mass index that's over 30. has high blood pressure that's not as well controlled, and is developing pre-diabetes. Obviously, these are illustrative examples, and individual outcomes are not solely predicated upon social determinants. However, as we've seen in the previous CDC data, the prevalence of certain conditions is much higher in lower socioeconomic areas. So this slide represents the population health framework that I've used for 15 plus years. Health plans are in the business, inherently of managing populations, whether the membership is 50,000, 250,000, or 1 million plus lives. And all health plans have resource constraints. No one can do everything for everyone. It is important to prioritize resources and target segments of the population to derive maximum benefit. These three steps are in a continuous process improvement framework. The first step is identification and risk stratification. First, you should collect and organize disparate data from multiple sources, including medical and pharmacy claims, consumer or patient level data from health risk assessments, provider data, and now social determinants of health data. You then might create a member profile that you can stratify by risk and then segment by chronic diseases or some other variable. The second step is interventions. Health plans offer a whole variety of interventions to try and improve the health of both the individual and a population. Health plans frequently organize their teams based upon functions such as utilization management, case management, disease management, and quality. Some try to take a more holistic view and tie these together with a common data source and health management platform. Health plans are offering digital health and mobile to try and engage consumers and try to collaborate with providers, perhaps with incentives, to close care gaps. They offer campaigns and rewards. A tremendous amount of resources is spent on interventions. The third part is outcomes. The so what? So we did all this stuff. What did we do to the population? Did we actually improve the health? It is vital to have a successful program to incorporate outcomes real time with the interventions with the various populations so you can assess how successful you are. And if you do this in a continuous process improvement framework, then you can make the modifications to your interventions, to the population, so that over time you'll have a thorough understanding of what works best with your population. When I look across the SDOH landscape of what are organizations doing today, I'm not really seeing a population health approach. Certainly, organizations would identify their high-risk members. It's frequently done with some type of a member survey that may be targeted, or sometimes at a state level for Medicaid may be mandatory. These are often quite cumbersome and expensive to carry out. Some organizations may do financial profiling by partnering with credit bureaus to leverage individual information. It's a great way to expand the data and get some specific information, but you really don't get community ratings from that, and it's quite expensive. Public health, I think, does obviously a solid job. However, that's usually at a state or county level and not granular enough to get into details of where a person actually lives. None of these approaches really triangulate community ratings, individual claims data, member health data, and other clinical data to create a solid profile of an individual's health and health history and their community rating. The second part that, what people are frequently doing in the market is if somebody is identified as high risk, then they're connected to various service organizations in an effort to improve an individual's, whole person health. Unfortunately, this is often transactional in nature, and it's difficult to assess the long-term impact on an individual or population. I'd now like to turn it over to Praveen Pant, our Senior Director of Analytics and Artificial Intelligence. This team is architecting the Z-Omega solution, and he will do a high-level thematic walkthrough on the approach, as well as discuss potential outcomes you should all consider.
Thank you, Dr. Single. Here, basically when you talked about the population health framework, we're basically taking that concept and expanding that and then building a solution out of it. So here on this slide, we were basically talking about our strategy. So we have focused on 5 major SDOH data strategies at this time. For neighborhood and physical environment, we're looking at housing affordability. Similarly, we're also looking for transportation access and access to food within certain distance. For education, we're also looking at the percentage of people with at least a high school education. And finally, for economic stability, we're focusing on the bottom quintile of the income as compared to the state median incomes. So we take this community level data from a variety of public government databases, I would say about 20 plus, which then goes through a data engineering and algorithm process within our organization, and then are mapped at the census tract level. So we then combine this information with our claims data as well as personal assessment data to create a complete holistic view of the member profile. So in the next slide, I'll be walking through the SDOH workflow. So in terms of identifying the member risk, where do we start? So it is very important to look beyond the obvious. What I mean by that is traditionally we have been focused more on individual level assessment using various screening tools that's available out there, like Prepare, Accountable Health, ACS related social needs screening, and so on. So this is extremely important, absolutely, but we may not always get a very holistic view of the population just by this approach. So therefore, in order for us to really understand the population as a whole and its needs, our SDOH workflow begins with mapping each member's address to a census tract. Again, we're mapping the information at the census tract, which is much more granular than the zip code. So by profiling an entire population's community risk, we are able to provide granular data on any members that have zero claims experience. So, and then we do have a methodology to summarize the data into one risk score. If a member comes up with a high risk, then we trigger an additional member level survey that can be sent automatically through a member app, or we can also ask through the telephone or clinical assistant. This short survey then gives a preliminary member risk rating, and if it's consistent with the high risk community ratings, then it prompts a deep dive intervention by a clinician or social worker. So after that, these care managers then perform a thorough assessment with a 20 to 40 questions targeted assessment to value the individual needs. The care manager then coordinates activity to provide optimized health and wellness. All of this is communicated bidirectionally with our digital health hub platform. And this is where we're also integrating with community level social service platforms as well. So once your needs are identified and what needs to be done, we can trigger that. And in the next slide, so this is a very high level visual of having the SDOH information literally at the fingertips of the care manager as they are interacting with the member. You got to remember that many of these interventions are for transactional items, such as reviewing a prior auth as part of the utilization management, or perhaps navigating the complex health system as part of case management. So by providing the summary of the community level ratings, the care manager would then be prompted to ask additional questions if the member was high risk. So, and then they can drive the intervention accordingly and also help them connect with the appropriate social community level social platforms as well. For example, Aunt Bertha, Unite Us, and so on. So on the next slide, this is basically, it gives us an overview of the SDOH rates across the entire population. So as you can see here, it's about 1.4 million population. It is important to understand the differences between low, medium, and high risk population, as well as the relationship between these different risk groups. For example, people that are high risk for education have much higher poverty levels. In addition, by identifying the high SDOH risk members, we can proactively work in addressing some of the clinical as well as social needs in peril than to wait for somebody who's going to develop a clinical risk, which is then much better for both member and the plan in managing the challenge together. So the next slide here, we are actually kind of like diving even deeper after understanding your populations, your high-risk populations. We're taking that, and now we're more like focusing on, what are the different chronic conditions that particular population may be vulnerable to. So, and this is, I really think that this is one of the most important aspect of, understanding a population, because this gives insight into, what are the different things, what are the different factors that is important for your population, to manage that population, even before you get any claims or any kind of member-related data.
Right. That's absolutely right, Praveen. I think this type of data is particularly useful for planning out strategic priorities and even understanding how to operationalize a social determinants of health intervention program, where to focus your resources, what to place attention on, and how to cast out goals for years to come. Having this level of information pulls the curtain away from high-level population-based information and really allows the strategic and operational leaders within the health plan to zoom in on what's most important and where the greatest potential for impact lies.
Yeah, absolutely. And one of the reason we're trying to put more focus on this is because this information will help you be proactive with the population. Because a lot of times you may have new members that have just signed up with your plan. You do not know what's happening with that, particular member. A lot of times you're just waiting for a claim to come in so that, then you can start working on it. But this will actually give you a head start. You can really understand, your population. You can really understand where that certain members will fall, and what are the different things that's happening within that population, where that where the member is, in terms of specific visits, medical drug adherence, A1C complete, and even the high SDOH risk like bed days. You can look at different factors here. So the next slide. So it's, once you identify your population, going back to the population health framework again, do the intervention, it's very important to track, really understand the outcome. Is it really improving? Or, how are the things, how are the social needs, what is the poverty now? Is the transportation need going down? Food insecurity, is it going down, up? It's important to keep track of that as well. And then I think together you'll be able to understand the population pretty well. I think I have a couple more slides, very similar. We can just go through this. Same thing here as well. The next slide. So again, this is, importance of measuring. Like when you are putting some kind of intervention process or plan together, what is your success rate? How are things happening down the road? So, and I think it's very important to track that outcome. Next slide. So in summary, basically, we do have to identify the population. With that, we have to trigger the interventions and then also track the outcomes. So incorporating the community level SDOH gives us an overview of the population and its need well ahead of time, which can then be channeled into the member level screening and assessment to further verify and drive appropriate intervention and then be able to track the outcome, which we call a whole person care. All right. So next slide.
Yeah, I think that wraps up the majority of our content, and we can move into question and answer session if we have any.
And yes, we do. Our first question today is what is the source of the data that you're using at the toward the beginning of your presentation? And is there a study that supports the numbers that you provided?
So yeah, I'll try to answer here, and then I'll let Dr. Singal and Dr. Swift answer some of the questions as well. Some of the, the data sources we're using is 20 plus government data sources that we're using, census, gov, IRS, and so on. And you want to ask something?
Yeah, so at the beginning, I think we were referring more to the statistics that I was quoting. So we do have citations on the slides. Much of the information comes from the Institute for Medicaid and for Innovation. It also comes from the World Health Organization, comes from various peer-reviewed medical journals, and the Center for Disease Control. And Dr. Singal, I'm not sure if you have other sources, but all the statistics, percentages, numbers, and data that we presented today are all validated with evidence-based sources.
Yeah, and I think just to add to that, the section that Praveen was showing, our strategy, we're linking to over 20 government databases and trying to get as granular as possible. So we take, we have working with our health plans, we have zip code level, obviously, but we actually have address level, and then can map that specifically to various government databases. And you'd be surprised once you get into the weeds of them, what the granularity that you can achieve. I mean, you can't pull up a person's individual IRS 1040, but you can pull up a census tract level pretty good financial information from the IRS. So that might be one example of, of the 20 plus databases. And then as Praveen mentioned, we triangulate with our own proprietary algorithms. And as far as having literature on, hey, how successful are we with that we don't have. But what we do have is, working with our health plans, we have our health plans in collaboration, their member level data, and then we actually have, the claims data. And then we can match up and see, okay, hey, in your population, in the lowest quintile of income, is your diabetes prevalence 3x the higher income levels? Is it 2x? Is it 50% higher? What's the complication rates? So you'd be surprised at how granular by working collaboratively with our health plans that we can get.
Absolutely.
Okay, with a follow-up to that, our attendee would like to see a complete list of citations, said that would be useful, and was wondering about the 20 government databases. Instead of listing them here, these questions will be in your attendee report, so along with everyone's email address, so they are listed per person. So you'll see that, and maybe you could send him that information after our webinar. Okay?
Sure. Yeah.
Yeah, and that may not be. I think certainly we're happy to share more information and contact us directly, but the exact 20 databases, I mean, that's taken hundreds of hours of work, and it's certainly not proprietary to Z Omega, but it's not something we would just list out and kind of give you a go-to manual. I mean, this has taken hundreds of hours of hard work, plus then the way that we then take that data and then put in our algorithms. But we're happy to talk in detail with anyone interested.
Okay. Next question is, what are some of the tools that you used to make the projections that you did?
So for the dashboard that you just saw, we use the standard visualization tools like Tableau, Power BI, but then for the integrated care management product, that's a proprietary tools we have.
And I think you could also add, Praveen, you and your team have built a pretty phenomenal database, using for the also machine learning and artificial intelligence.
Absolutely.
And I think it's one of the other big things that Z Omega brings to the table. And yeah, I think you could share some of that, Hadoop and Spark and some of, not only doing the base level demographics of, of your population of 250,000 lives, what percentage are in a lower socioeconomic area versus higher, and what's the education impacts, but then the machine learning potentially on top of it, the so what, how do we triangulate, hundreds of other use cases that you can spin off. But now I'm talking like a database scientist, which I'm not, so that's more you.
So no, I mean, from the machine learning perspective, obviously we're using, basically enterprise standard tools like, scikit-learn, Python, Hadoop, Spark. So those are the tools we're using for that as well. But more on the visualization side, we are, leveraging Power BI as well as Tableau.
Okay. Can you tell us the time frame over which the outcomes are to be addressed?
Yeah, if I take that question, I mean, I think what we generally want with our health plans is to get historical, 2 years of data, including eligibility over 2 years, and even the migration of, some members with all the eligibility address updates. So as people change from one community to the next, that's for us interesting, as it relates to SDOH, versus people that stay in the same communities. So if we can get, minimum 2, 3 years or 4 years is better, of historical eligibility data, including, age. We don't have to have the exact date of birth, but age. And then, get a tremendous amount of more information if we layer claims data on that, and there's ways to do it in a way where we can hide the actual member name with the, the whole 12-digit alphanumeric, codes. And but those are the things to really get a base assessment of the population and the risks, and going forward where you may want to apply some of your interventions that are more targeting these social determinants.
Okay. Do you have some definitions of and metrics for your community ratings?
I think for me to answer this is probably more, we try to really break things down into quintiles and often do things at a state median level as opposed to national, but maybe you can talk a little bit about that.
So, we're basically based on, what data is available out there, then we do, again, our internal research, our data scientists and the team does an internal research. As a result of that, then we're able to group certain, the SDOH data together to come up with a risk score, which then further stratify into high, medium, and low. That's how we do it. And then we rate certain community as high. Well, I wouldn't say community, but more like census tract as high, or certain census tract as low, and certain census tract as medium.
And I think one of the other advantages of going to a census tract level is census tracts. One of the interesting parts about that is, number one, they're very granular. There's often multiple census tracts in the zip code. And number two, each census tract has around the same number of people. And so hence being able to calculate percentiles across census tracts in a, statewide is a really great way to compare, one group of people versus another. And so the mapping of census tracts is a fair amount of work. And I think then triangulating these government databases to the census tract gives you pretty incredible visibility.
So when you get the data from the government sites, these are vast amount of data, very raw data. So you have to really put a lot of data engineering to it to make meanings out of it, or draw the meanings out of it. So our team here, they're very, I would say, I'm very proud of the team. We spend hundreds of hours just curating that data, and then as a result, we're able to really understand it and put it out into our product.
Okay, follow up on that. Isn't block group more granular than census tract? And is there a reason why census tract level data is used instead of block group level?
Yeah, that's a correct statement. We do go to the block level. I probably oversimplified by saying census tract. It actually is at the block level. Is that correct, Praveen?
Yeah, I mean, it's almost at the block level. Yes, absolutely.
Okay. Not all of the, I guess as a follow-up, not all of the government databases that we triangulate to go down to the block level. We map to the block level and then bridge it with the various databases. Some go down to that level, some don't.
That is correct.
Okay. Our next question. Is this data available in the ID and Strat tool to help prioritize at-risk members within a CM cohort?
You know, we actually have a special guest for that answer. So I'm going to introduce Sandra Hewitt, our Chief Nursing Officer and architect of our own proprietary ID and Strat algorithm. So maybe, Sandra, you can kick that off.
Absolutely. So yes, we use very similar algorithms within the data to identify and stratify high risk, moderate and low risk patients as well. We are going to be incorporating this SDOH data as well as other pieces of known SDOH data in our algorithms as we speak today. So that information is very much available for those high-risk patients that do fall into a case management cohort that you want to manage as part of your high-risk population. I think what we've been talking about today is that other 80% of the population, or actually almost 90% of the population that doesn't fall into a case management cohort. But if you don't start to do some sort of management with those patients, you're really losing a lot of that ability to prevent disease and prevent progression of chronic conditions. So when you're looking at holistic management, population health management, which is where healthcare is going, it's important to still manage that case management cohort with very detailed identification and stratification algorithms. But more importantly, it's important to really stratify and manage and put programs into place in the community for your entire population. And this is kind of what we're doing with all of our programs that we have to manage holistically the entire population. I hope that helps answer your question.
Okay. Next question is, I know that a company called MCG has social determinant of health assessments in their chronic care guidelines. Does Z-Omega offer any type of software integration for that evidence-based content to help some of these challenges?
Yes, I mean, we're fully integrated with both MCG and Interqual Change Health, and the assessments are readily, as content are readily available.
And also to add, our own integrated proprietary clinical content is very, very involved in bringing in holistic care management to all of our clinical products as well. And we utilize all of the, NCQA and URAC standards and guidelines for developing those. So utilization of our proprietary content or external content through integrations is very much something that is important to do and lends itself more to this holistic management.
Okay, next question. How does the social determinants of health affect other populations such as commercial, marketplace, and Medicare?
I mean, I think it's pretty dramatic. You know, obviously we focused on Medicaid in this presentation, but you know, you can see across all ages, economic strata, what the differences are. And I think one of the assumptions people make is, well, Medicaid's low income, they all have SDOH issues. I think you'd be surprised what percentage of Medicaid members live in the highest income areas. It's not zero. It's closer to often 10%. And then similarly, commercial age, you know, people that are working and, you know, a job as per those the personas with, I think it was Mary and Nora. Some of them are in, you know, still lower socioeconomic areas. They might be taking care of a parent and just have never moved. And they will have different risk factors. They will have a different persona. Their interests, their ability to do things may be impacted. So I think it's absolutely relevant at all groups and demographics. And actually, if I you know, digress for a second, I grew up in an area, you know, in Romulus, which is where the airport is in Detroit. It was definitely a lower socioeconomic area up to the age of 10, and I was 2 grade levels ahead of my classmates. And you know, I was in 5th grade math as a 3-foot-tall 3rd grader. Well, in 5th grade, we moved to a different town in Troy, and it was one of the higher socioeconomic area. I was a year and a half behind. So it tells you, I mean, it was just so dramatic to me. And some people have used that phrase, that zip code is destiny. And I think it was shocking. And I think once I looked at all of the CDC data and we're starting to see more and more evidence, a person where they live, it has a huge impact on their overall life.
And I would just add, this is Tricia, and Dr. Singal is absolutely right, but social determinants affects all of us. It's just what bits and pieces impact us the most. So there was a recent study put out that cross-referenced political affiliation and preferences with school bullying and violence, which often leads to suicidal ideation and adolescent depression. And the results of that are very interesting, and it begs the question to ask of whether political affiliation will become a determinant of health as we learn more about that. So, yeah, the whole concept here of social factors, physical, environmental factors, and things that are linked to your zip code are not exclusive to those of a lower socioeconomic status. They impact us all. It's just a different recipe, and I think that lends itself well to the premise of whole person care and household centered care, and that's just really the direction we need to move in the future.
Okay, next question. What about the Medicaid homeless population with mental illness and substance use disorders? Which would be better for these members, housing or smartphones? Both are competing with food, but they need follow-up care with their providers.
That's a tough question. I'd say we are not the experts in that. We can help assess various interventions and kind of track outcomes. Yeah, that's the only comment I have.
We'll have to plug the data into our process, and then we'll be able to tell you the results.
Now, having said that, on the behavioral health side, we do a tremendous amount of profiling. We have some standalone behavioral health clients, and we're able to show the differences in people with mental health needs versus those without. And you see obviously a huge difference in emergency room utilization, and that's often a time that our algorithms will catch people and then enroll them in case management early and start to engage them. And often it's a lot more social interventions as opposed to traditional clinical
And I would just add, I just happen to have some experience working in county level healthcare, and I was surprised to learn that actually a large percentage of folks that are homeless have cell phones. And the most recent studies indicate that over 92-93% of Americans actually have access to a cell phone. The percentage is a little smaller for a smartphone, but it's definitely a misconception if we are to assume that insecure housing is related to not having access to a device, because that's just more common than I think we assume it is. But yeah, definitely customized interventions and programs are in call for these sorts of questions.
Okay. I'm going to combine a couple of our questions because they both deal with dental health. One, would it be possible to modify to look at oral health outcomes based on social determinants of health? And do you work with dental plans? Are you confident your model will be effective when the focus is dental and not medical?
That's a great question. The CDC does track dental caries across different populations. We have and Sandra, you know this better than I do, but I believe we have a dental module or a few questions on it. But as of now, we're not working with any dental plan, or there's no dental data we're receiving as part of our numerous health plans. We would love to do that.
Yeah, actually, we do have a lot of questions in our assessment content around dental care, because we know that's part of being a person. And we do have a couple of clients that have incorporated dental programs and what have you within their case management program. So we have some data on that from our clients, but again, it's a forgotten item in most health plans views, but it is a very important one to look at. So again, I think that dental care comes with claims, with coding, and what have you as well. So if a health plan gets the data, then that would be something that could be incorporated into our algorithms, ID and Strat, assessment data, etc. It's another piece of the puzzle.
Okay. Well, that looks like it takes care of our questions for today. Just a reminder that the slide deck and recording will be posted on the ACAP website by tomorrow morning. Other than that, I'd like to thank all our attendees for taking time out of their day to join us for our very informative webinar by Z Omega. I'd like to thank everyone from Z Omega, all the presenters, for taking time to present this webinar to our attendees. So thank you and have a great afternoon.
Thank you, everyone.
Thank you.